Thank you, everybody. This is actually my first COS meeting, so it's an honor to be here. It's kind of humbling to be in the presence of all these great mission ophthalmologists. I'm kind of a nobody in the world of ophthalmology, and it's only by God's grace that I'm here. You know, I'm just thankful to Him that I even am an ophthalmologist. But you know, God opens doors, and I'm very thankful for the opportunities I had both in the practice. The practice that I'm at is just amazing. We get to pray with patients if they wish before every surgery. We're very high volume, efficient, and I'm still able to do as many complex cases as I wish. I am also thankful for all the mission experience that I've had working with Dr. Jacob and everything. And you know, I'm just a general ophthalmologist. I'm not a specialist. I'm not special. But you know, I like the story about when Jesus healed the blind. When he took dirt and spit on it and placed it on the eye to cure his blindness. And that kind of bothered me when I was younger reading that story. But actually really encouraging to me because, you know, if God can take his spit and mix it with some dirt from this earth, I guess I have some hope that he can use me to carry out his work. So we're kind of behind schedule, so if you guys are hungry, you can leave at any time. If I won't be offended. If you guys have questions at any time, make sure just let me know. We can stop. This is informal. I'm going to try to hurry through the cases. I have a lot of cases. I tried to pick the ones that are my favorite, but there is just a lot of really cool cases. So we're going to go through different iris defects and how to repair them. I kind of categorize iris defects in, you know, a sectoral defect from trauma, large iridectomies, colobomas, iridodialysis kind of sectoral. Then you have big blown pupils from trauma, angle closure, ischemia. Then you have a combination of both. When people have like ischemia and then they get hit in the eye, they have blown pupils and they're missing a sector. And so there's a combination of stuff that we're going to deal with. The next few pictures are really inspirational to me because iris repair, mission work, and everything really takes outside the box thinking. So you see this car here. If your air conditioning is not working, you put a window air conditioning. Then you have to have a generator to run it, right? Outside the box thinking. And in mission field, and this comes in handy, and especially in these complex surgery, I don't know what to do sometimes. You know, I tell the staff, we're going to do a really cool case. I have no idea what I'm going to do. I have a plan, but it could be completely different, and we just have to pray and see how it goes. You know, if you're not comfortable on your motorbike, you put a chair in the back. If someone steals your Mercedes sign, you make your own. If your windshield wiper is not working, you clean the windshield. So a lot of things that, you know, I learned, you know, from Dr. Jacob. You don't really need very much. And, you know, my experience there, it's kind of my boot camp to go to India, and it's very difficult my first time. But I did go again this year, and it's better. But, you know, on top of having those difficult situations, half the instruments are broken. I don't know how he works with them. The 0.1 tooths have no teeth. They're completely smooth. The scissors are sometimes missing a prong. But he's just an amazing teacher and inspirational. So let's talk about bread and butter of iris repair. These are like the two things that I use on a regular basis. Now, so these are by Ethicon, and there's probably other brands, but tonoproline is your bread and butter for iris repair. Now, there's the straight and the curved, and I can tell you what I use for each of them. For iris-only work, where you're only suturing iris to iris, I like to use the curve because you know, you have to fish the needle. It has to go down and it has to come back up again, and that's why I use a curved needle. The needles are shorter than the straight needles, about a 3 millimeter difference. So when you're doing iridodialysis repair, you need a longer needle because sometimes it doesn't reach all the way across from limbus to limbus, so you need the straight needle. When you're doing a lot of repair and you're trying to save money, these sutures are a lot longer. See, 8 inches versus 4 inches. So if you're trying to save money, and even though I usually try to be efficient, and so sometimes I'm suturing to the last like half an inch, but yeah, sometimes the straight needles, you can also bend the straight needles, but that's kind of the rule of thumb that I have. Instrumentation. You don't really need a lot, but these are some of the forceps that are available to us by MST. We have mainly three that I use for iris repair. You have the micro holder, so this is here's a close-up view. They have little serrated teeth on them. These are the Ahmed micro grasper forceps, and then these are the Cybele capsulorhexis forceps, and they're all 23 gauge. They'll fit through a side port, and they're very useful. Now, if I only could pick one tool to do almost everything, I would pick this one right here, and that's the micro holder. You can use this tool for almost everything. You can use it to grab an IOL to cut it in half if you need an IOL exchange. You can use it to grab haptics for the Yamani technique. You can use it to grab iris. So this is like the Swiss Army of all the tools. And it's also oriented a special way that I'll get into later. But second would probably be this item here, the micro grasper, and then this one I don't really see a whole lot of use, but once in a while it comes in handy. Now, MST offers two different types of handles. There's a regular handle, which I recommend, and there's a 360 swiveling handle. This one's really annoying because when you're hanging onto something, you expect your hand to be in the same direction, but if you bump it, then the head swivels and it goes somewhere that you don't think it's supposed to go. So I find it a little bit clunky, and I would just recommend the regular straight handle. So going in terms of knot tying, the number one knot that I use is the modified seeps or sliding knot. I just want to see a hands, like how many people use this once in a while on a regular basis and know how to use that suture. So a good number of people. And so that comes into many uses. We're going to also touch on cerclage pupiloplasty. A newer technique that I've also been experimenting with is the modified sewing machine method, and other types of pupiloplasty shaping techniques here. I know you guys that have done the seeps or not have seen some of these diagrams. And I remember when I was in middle residency, I was really excited about this, and it was probably about 8-10 years ago when I was in middle residency, and I was like, this is so confusing. I can't, there's like so many pictures, and it's really hard to tell. And the people that were doing it that I watched were using the tail, and they were fishing it in the loop, and I was like, why can't we just treat it like an instrument tie, like a regular suture, and just forget that there's a loop there? And so that's how I've always done it. And I was going to come up with a demo video how to do it, and I was crunched on time, so I'm like, okay, let's search YouTube, the #1 learning resource available on the internet, right? You can learn anything with Google and YouTube. And there's already a video there, and this is a video by Dr. Aries, Brandon Aries. And you might have seen this video, but I thought it was, why reinvent a wheel when, it's already been done. So I thought it was very good. And he demonstrates how I do it, where you treat the loop like a suture and you can instrument tie it. So here you are, you're going to go through one paracentesis on the right, go through the iris defect, go through the second one, then you come out either through a paracentesis, or you can actually just go through the limbus or the cornea. Then you take a hook. My preferred hook is a Bond iris hook, which is a really tiny little hook that has it kind of comes back at you. But if you don't have that, a straight Sinski hook will work. And if you're really in a pinch, you can just twist your hand with an angled Sinski and it will work. But once you get the loop, okay, so now you have the suture here. Now, if you just cut off the suture and you were just to tie these two together, that would be just like a regular knot, right? You just take this loop, you loop it around 3 times or 4 times or how many times you want to do, and you just pull that string just like a regular instrument tie. So that's how I've been doing it from the very beginning. And so once you get this loop, instead of pulling this part, because this is all the way on this side, then you just pull that knot, pull this string over here. And then knot just goes back into the eye. Okay, so this is, I think, is the best way because #1, you don't get as tangled. You can do multiple passes, and you probably heard about the 4-throw pupiloplasty. And what I found that if you use 4 throws, you only need to do it once. I was a little bit skeptical in the beginning, but now I do it all the time. Saves a lot of time instead of having to fish it 2 or 3 times. You just take it out, loop it 4 times. Pull it through, then you're done. Okay, so that kind of, let's keep going for the sake of time. Okay, so here's a case. Here's a patient that was referred. Patient had a trauma, lens fell in the bag, retina surgery. Retina specialist went and took the lens out. Was a phakic, and they accidentally bit a piece of iris out. So since we're going to do the skull fixation tomorrow, I kind of skipped that part, so the lens is already in the eye. Now we're going to fix this defect. Now, it's not a huge defect, but iris defects can be so annoying to some patients, debilitating glare, that I try to fix every iris defect I find. My two big passions are in ophthalmology are, besides just surgery in general, is I really love iris repair because there's a lot of art to it, and I have a huge passion for skull fixated lenses, which we'll deal with tomorrow. So here we are, we just went through a paracentesis, we went through a chunk of iris here, went through another chunk of iris, and some people advocate for making a paracentesis and then you dock the needle with a cannula. You don't even have to do that, you just poke through. The needle is so tiny. And there's an advantage for that, because if you poke through, there's no way that the needle can slip back. And that comes in handy when the suture gets really, really short and you're pulling and the actual needle actually gets flush with the limbus. This way, it's not going to go back into the eye, and it's a pinpoint hole. Sometimes the suture gets all tangled up and all the water gets all surface tension and it just sticks together. Just take a Wexel, just touch it, and it just pops open in most cases, and then you have a nice loop. Now sometimes you don't know which loop you're holding. Are you holding the top suture or the bottom suture? So you just do a test, you just tug. If it's tugging and the suture that's coming out of the eye, that's the one you want. If it's the bottom one, then iris will start tugging. And we'll go over many of these seeps or knots. So here I'm doing a 4th row, so I only do it once. And here I go, do 4th rows, make sure you don't get tangled. And it looks like a tangled mess there, but it actually doesn't get stuck in most cases, and you just pull it in. There you go, 1. But I'm not really happy. There's a little dimple here, there's a tiny little hole here, which probably wouldn't cause much problem, but you can see there's transillumination there. It looks like a PI. I'm not happy with that, so I'm going to put another seep cert knot there. So here I am just using some micro forceps, micro scissors actually. If you don't have micro scissors, you could probably stick a Van Ness through the main incision and cut it. I've done that through the mission field when we don't have anything. So here I am again going through a paracentesis. I want to close that little tiny hole there. So you want to make sure you're through the paracentesis and not catching some corneal fibers, otherwise you won't be able to fish it out. So there I am, once it's a small defect, you really don't need another instrument to hold it. You can just use the counter tension of the iris and then you can just go through. Okay, so now we got to engage the second part of the iris. Now you can just go through the limbus there and then you pull it out. And there you go, fish it out with a Sinski, or in this case a Bond iris hook. See, now there's a little bit of water, it's all stuck. You just get a Wexel. I think I got a Wexel. Oh, maybe. Yeah, sometimes it goes all over the place. You just try to sort out your sutures, suture management. It's a pretty big loop. Now, if you're doing a 4th row, you need to actually pull quite a bit of suture because it winds quite a bit around the forceps, as you see. And even in this case, because it's a curved needle and it's only a 4-inch suture, it gets short after you do it a few times. So here we go. Getting the suture off the forceps, it's the 4th row. It doesn't really matter which way you go, right? Because you're only doing one suture. If you do backhand or forehand, it's the same. So there we go. There's a little divot here. I'm still not happy. In hindsight, I probably could have just left it, but since I'm kind of OCD in some of these things, I go ahead and put a last suture there, and for the sake of time, we're not going to go through that. But same concept, going through, pulling suture out, and making a little bit more round. Okay, so here's that Wexel trick. You just touch the suture. Usually the loop opens up after the water goes away. Now I'm doing another 4th row. Now you can really see how short the suture gets because now the needle's all the way stuck at the limbus, so there's barely any suture left, and you don't want to pull the other suture back into the eye. And if that happens, don't panic. You just get your micro forceps, go back into the eye, find the tail, and pull it out. Never panic in surgery. Just pull it out. And that's a little better. So in this case, we did a skull fixated lens, and we did pupil repair. So that's the case there. Okay, any questions? So very useful. Seeps or knots. Here's a case of cataract and iris colobomas. You can go ahead and suture that. It's not a perfectly round pupil, and then I'll show some techniques on how to round a pupil out a little bit more later at the end of the lecture. Here's the other eye. We do another iris coloboma repair. This is a young girl. She's about 20-some, 26, I believe. She had an eye stick fell when she was like 2 years old or 3 years old in Mexico. Stabbed her eye, no lens. It's kind of a mess of an eye, but with proper suturing techniques, you can reconstruct it. I will say that, iris, I always tell patients, sometimes I can't repair the pupil because you'll cheese wire. The patients that I've seen that cheese wire a lot are patients that have trauma when they're young. I don't know why, but when they have trauma in their 30s or the 20s, or even that they have 5 operations, it's not as brittle. When they have trauma in their single digits, I guess, it just tears. In this case, I couldn't get it perfectly round, and for the sake of time, I can't really show this case. We'll keep going. But a little bit cat-eyed. I tried to put a suture at cheese wired, so I just left a little bit cat-eyed. But she went from like light perception to, she had severe amblyopia, but she was at least, I think, 2400, 2200. Seeing a little better. Yeah, corneal scar in the front there. Okay, move on. Here's a case. This is a 40-something-year-old, I think it's 40s, mid-40s. She had a bungee cord hit her eye. So not only does she have iridodialysis here, she also has a blown pupil. This is a non-dilated pupil. There might be a little bit of sphincter activity here, but most of the pupil is pretty tonic. She also has some vitreous coming around the zonules, which is hard to see in the picture. And you can see there's a pigment stuck to the vitreous. So how do we tackle this case? So in cases where you have combined iridodialysis repair and you're trying to fix a traumatic mydriasis, I usually fix the dialysis first. So in this case, I already did the cataract since we had to do quite a bit of vitrectomy to get the vitreous out of the AC, and I think I had to stabilize the capsule with using capsule hooks. But now that that's done, and I was pretty happy with the centration, I might have put a CTR, can't remember. But so we go to the area of dialysis. Since I'm going to do a cerclage pupilloplasty, I go ahead and just prepare it, and for access, you need 4 paracentesis. But since we're going to go and fix this dialysis first. Now I'm using probably the wrong needle here. Remember I said in the beginning you probably want a straight needle when you're doing a dialysis repair, when you're suturing iris to sclera, because the needle's not long enough. Here you can see from my mistakes how it's harder. You want to get as peripheral as you can. So now I'm running out of needle and go there. Notice I'm not making any flaps, and there's a reason. The more manipulation you do to the sclera, it just doesn't heal as well, and the eye is just weaker there. You have to do lots of massive cautery. I do like cautery. After being in India, blood doesn't bother me as much anymore. So here I'm doing a second pass. This is a double arm suture. So we have to make sure that we don't get caught on the paracentesis here. Going to the edge, and here's that capsulorhexis forceps I just wanted to try. I really have only used this few times, but once in a while it's just kind of fun to use something new. Again, here the needle's so short, I'm running out of needle. So sometimes instead of pushing the needle, you push the sclera that direction. And for iris repair, you want about a millimeter and a half posterior to the limbus. And you can just play it by ear. You don't have to really measure it. Just eyeball it and see how it compares to the other surrounding tissues. I go ahead and cut one of the needles off. I tie the knot, but I don't. I do a 1-1-1 suture tie, and that makes the knot really small. So I do 1-1. So the first 2 ties are in the same direction, and then I usually do 2. And that makes a slip knot. Then I can adjust the tension. And here I am. That's a slip knot. That might be a little tight. So here, once I do the 2, I can still adjust it. I want to make sure that I didn't make it too tight. Since I have to do a cerclage pupilloplasty after that, I want to be able to stretch and make sure that I have enough, that's not way too tight. Now the difference between suturing irises and IOLs is tennoprolene should last forever. Now the suture might not last forever, but iris pretty much sticks to everything. You have it touching the cornea, it sticks to the cornea. So I'm not really worried about this degrading over time. Even if the suture completely disappears, that little bit of nubbin just stuck there should be able to stick it. Now I'm using a Sinski. I'm really forcing the knot into the needle track that I had. And you can push quite hard. And once you push the needle, push the Sinski at that hole, it can be either side, you can actually rotate the knot in. So now you just have a smooth suture, and I just left that. Now I'm going to do the cerclage. Cerclages are a little tricky. You need a little bit of finesse with the needle because they can flip all around and do crazy things. It's just, just slow and steady. Now, the cerclage, you're only actually poking the needle through the iris on the underside. So you poke the iris on the posterior side of the iris. Then once you see it on top, you wrap it around the pupillary border. Then you poke it again. So you can see it's like a spiral effect around the pupil, the pupillary border there. Does that make sense? So that actually saves some time. I used to go in and out, in and out. And number one, there's more iris manipulation, and there's more chance of having a skipped area. So right there, I just did quickly, what I did was dock the needle into a cannula. I usually irrigate and hydrodissect with a 25 gauge cannula, which fits beautifully. You just stick it through the paracentesis, push the needle through the hub, and then you just pull it out. That will prevent you from accidentally poking through and creating another track, and then when you come back in, then your suture is going to be looped around the cornea there. So we might fast forward this for the sake of time, but here I am just continuing around the border here. So for the sake of time, maybe we'll do 2 quadrants and then we'll see what happens. You're going around, poking through the underside of the iris, and then just looping around, okay? And then once you get to the end, or towards one of the paracentesis, so you're doing about 90 degrees each quadrant. And then you push the 25 gauge cannula, then you dock the needle, then you can pull the needle out. So you have 2 quadrants. Those are the easier quadrants because you're using your left hand. Once you go into this quadrant, you switch hands. Now you're using my left hand. And then you use your right hand to guide it. When I was born, I talked to my parents. They were like, yeah, you were left-handed when you were born. And then we corrected you of that ailment. And that's why my handwriting is so bad. At least that's how I blame it on that. But it actually comes in handies. And that sometimes it's easier to use your left hand. But in this case, you can use your right hand if you're trying to round a corner. But here again, cannulate. All right, so we won't bore you. We did the last quadrant. Now it comes down to suture tying. Now there's 2 ways you can do this. You can tie the knot outside, which kind of pulls on the iris. I've done so many of these, I haven't had any problems pulling the iris. You just have to go gently. Other people advocate by actually tying the knot in the eye, but I just feel that's just a lot more work. You kind of ease the knot in. So you just kind of pull, release, and the knot kind of eventually works its way into the eye. In this case, I usually do a 3 throw, and then I cinch it off with a 1 and a 1. So here I am slowly pulling the iris back together again. Now, it looks like I skipped an area here. So this is already in the back of my brain. So that's so ugly. It's scalloped, and then I missed a spot. But there's a technique you can actually fix this after the fact. So once we get to that. Then I also noticed that there's some more iridodialysis than I thought, so I eventually put another suture there, another kind of a mattress suture with a double arm. But eventually you want to size the pupil to about 3.5 millimeters to 4 millimeters. That's about the sweet spot where you have not too much aberration from a dilated pupil, but not too small that you get diffraction or poor night vision. So once I get it sized to what I want, let's go skip ahead because we're short on time. I go ahead and fix that, and we don't need to see that. This is important. So whatever you miss, you can do a seeps knot to actually tie the iris to the suture that you have the cerclage. So here I am going through the iris. You go under your cerclage suture. Then you do your normal seeps knot. Then it cinches. It's like a cable tie. You tie the tissue to the other suture, the cerclage suture. So I'm much happier now that it's a little bit more round. And so there you go. So it's starting to take shape. And sometimes it just takes a little bit of time, but as you do more and more of them, they actually get fun and you get faster, just like anything else. So there we go. For the sake of time, I'll skip ahead. I had some tissue lying around from, I think, another pterygium case I did earlier. So go ahead and glued all the, I was like, I'm tired of suturing, so let's just glue all the conj. It's usually a little bit less irritating to the eye. So here's post-op day 1, actually. Pretty good. Not too much corneal edema. Pretty clear. This is about a month out. and she's actually happy. She's a very active snowboarder and mountain person, so she was happy that she could not get a lot of glare from. Oh, here you go. You can see the little blue Prolene sutures on that side where we sutured. Any questions on this? Yeah. Yeah.
When you said you did the 3-1-1, you're working it into the eye.
Uh-huh.
How can you move it once you've done the
So you just do the 3. You don't do the
Yeah.
1-1. So you do the 3, and you're just pulling and then releasing and pulling and releasing, and then eventually it just gets tighter and tighter by itself.
I understand that bit, but then when you put the 1 on,
Then when you do the 1, so you do it shy of like your target, because when you do your 1, then it actually pushes a little deeper. So when you're almost there, you do your cinching knot, and then you do your last knot, and then it ends up usually pretty perfect. And if you're half a millimeter off, it's not a big deal. The patients, in this case, you're usually pretty happy with whatever you do.
Everybody's got it down, Jason, it looks like.
Yeah? Okay. But it's a huge thing. Like, this is my very first pupiloplasty case. This guy was like this for 40 years in a mature cataract. And yeah, I was a little bit scalped, but functionally he was great. He was seeing 20/15 uncorrected after the surgery. Here's a case where he had an angle closure with mature cataract, and then here's a post-op. And how are we doing with time? No time?
You got about 3 minutes.
3 minutes. Okay, then we got to skip a bunch of cases then.
We can go longer. Is everybody want to go longer, 10 more minutes? 10 more minutes.
10 minutes? Okay, I'll try to hurry. There are some cases where you don't need to do a cerclage. In this case, you have the same thing, trauma and blown pupil, but he's not blown completely. You can kind of look by the iris border that there's some sphincter movement, and I usually just shine a light, bright, dim. He has probably about one sector of iris working. So what I did was, in those cases, you can actually use the seeps knot, and I won't go through the surgery, but actually I can just quickly fast forward. So you can see I go ahead and do my normal anchor, and just what you saw from before. But because the pupil sphincter is not working on the inferior side, I go ahead and put a seeps knot and just zip it up, if that makes sense. Maybe it doesn't. Hopefully it will. And just keep going it. And if you don't like it, just keep putting more sutures. There's usually a sweet spot. If you put too many sutures, sometimes the iris can get ratty. But here's a post-op of the picture. You can see there's like 1, 2, 3, 4. I think there's like 3 or 4 seeps. And then the light, actually, the pupil's still working. So, this give and take. This is a little bit teardrop shaped. Not a big deal, but less manipulation. So you kind of make that judgment pre-op. Now, when you get chronic iridodialysis, this is more difficult because this guy had this for like 20 years. He got hit by a BB when he was 12 years old. Now he was in his 40s, mature cataract. Because the pupil is so displaced, he was like count fingers vision. There's nose nodules here, and the tissue tends to scar on itself. In those cases, you have to free the scar tissue. So we won't go through let me go through what I mean by scar tissue here. So, hold on. Okay, so now first thing, I got this cataract surgery done, put a CTR. You flip the iris over on itself, or upside down, and you're looking at the back side. You have to cut that membrane, because otherwise the whole pupil is going to be sutured to the sclera. Okay, so it's a little bit meticulous and tedious work, but once you do it, then you'll be happy that you did. So I'm just using MST horizontal duet scissors there. And you have to cut that membrane, otherwise the pupil won't look fun. It's always going to look a little funky, but it's going to look worse because it's all crumpled up on itself. I did a case a couple weeks ago, ruptured globe. The iris was outside of the eye. The person that fixed it just stuffed it all back in. A couple months later, I came to repair the pupil. You have to, and then same thing, had to kind of figure out what's what and peel. And so now that I kind of figured it out, same thing, tie it to for the sake of time, I'm just going to rush through this. Rotate the knot. I do a whole bunch of horizontal mattress kind of ish sutures, and the pupil starts to take shape, and the pupil doesn't really look around, so I add a seep strip on the bottom and put another horizontal because there's a little bit of dialysis there. End up doing a cerclage all the way around. but I don't want to belabor the point of doing cerclage. So once the case is done, at the very end, pupil looks a little bit more normal. It's not going to be perfect, but sometimes you're working with missing tissue or scar tissue. It's really hard to make it perfect. So here's a patient post-op. It's not perfect, but he's actually seeing pretty well and he's pretty happy. Sometimes if I think there's going to be a lot of inflammation, I'll go ahead and give subtenons and then just watch, and then if they're really inflamed, I go and, you know, put in Durezol or something. But usually QID pred is good enough. These cases are probably the hardest. This is a case where the patient had a dislocated lens. I think retina took it out. So it's a post-vitrectomy. I think they tried to repair the iris, but somehow it got ripped out, and so we're missing iris from about 11:45 to about 2:30 position, and it's blown, and they're aphakic. So we'll go over the actual skull fixation part tomorrow, and then so I have no idea what I'm doing at this point. I'm like, how am I going to fix this hole? Sometimes you can't. So I'm like, well, I know how to do cerclage, so let's do that. I'm just going to pretend there's nothing. I just skip this area and see what happens. So that's what I skip the area and just go all the way across. And then the cerclage looks horrible. It looks like a keyhole. And like, that looks bad. So I'm like, well, I'm going to put some seeps or knots there and close that defect. Some irises can't do this, but this iris had enough pliability. So just kind of play it by ear. In this case, if it's a missing chunk of iris can stretch a long ways. Now there's artificial irises, and some people are like, why not just put an artificial iris in? Well, we're very thankful that the Human Optics has artificial iris approved this year, and I'm very excited to use it. But if you can save the original iris, it's going to be always better, cosmetically and functionally. You don't have a piece of hardware that's could be bumping up and doing something. And in cases like this where they have no capsule, they're really hard to put in because you have to suture them. So here I am this far. There's a wedge of iris missing. So I'm like, oh, should I just leave it? It's like a huge iridectomy. Here I am tightening the cerclage and making this wedge bigger. So then I started thinking while I'm doing this, and like, well, in plastic surgery, when they do facial flaps, they cut a big piece of cancer out, they can like rotate flaps and pull it in. So I'm like, I got an idea. This area looks really thin, but this area looks actually pretty beefy. I think there's some material there. So what I decided to do is put a double arm suture here and rotate this into this area of defect. So let me fast forward to the area when I do that. I'm like, okay, I think this is stretchy enough. Let's go ahead and put a suture through there, and there you can go. Like, it actually is closing the hole a little bit. So, and at that point, I'm like, I'm pretty happy with that. I mean, I probably could put a suture there, and I was so debating it. I'm like, it's teardropped, and I wanted to fix it, but at that time, I'm like, well, something's going to go wrong, and I'm going to regret it, so I'm just going to leave it. So this is a patient, I think, either 1 day post-op or 1 week post-op. Yeah, it's not perfect. I'm still kicking myself. I could have probably put another suture there, but the eyelid is covering most of it when they're in a normal looking position. Okay, looks like I have a couple minutes. All right, what do you do when you have iridodialysis in a phakic patient, in a young patient? So this is like a 22-year-old, had a rock hit her eye when she was like 10, got this dialysis, no cataract. Oh, that's tricky. When I'm doing iridodialysis, sometimes the lens can flick, and then you just have the tail or some part of the needle just hit the lens, and you get a cataract, and then they have to get cataract surgery, and they lose their accommodation. So I wanted to try something new. So I saw this on YouTube. This is modified sewing machine technique. I wanted to try it. So originally introduced by Dr. Kumar from India, and was modified by Dr. Shantarova from Russia. This is so from India, this is the original technique. You get a tenylproline suture. Oh, let's go back. Whoa, that's fast. And you get I use a 27 gauge needle. You cut you only need is the suture. You cut the needles off both sides. You thread the needle into the hub of this needle, the 27 gauge needle. All right. And then you make either a scleral flap or a scleral groove. Then you go through a main incision, works well, gives you more manipulation. You engage some iris tissue, come out, pull it, pull a loop. So it's like a sewing machine. It's pretty cool. That way your needle stays very straight and very secure, so you don't accidentally touch the lens. So originally they cut the loops like this and they tied knots. The modified technique, you leave the loops intact, which I think is brilliant, and you just take the tail and you put it through all the loops and you just tie one knot and it stays. So that's pretty cool. So let's see how it actually works. So that's that same patient. Go ahead and do my peritomy in the bottom. Fill it with viscoelastic. I already marked about 1.5 millimeters posterior to limbus. I scratched it with a diamond paracentesis knife just to make a groove. And once there's a groove, the suture can just settle there, and then the sclera should go through. See, this is a Prolene needle, a Prolene suture, 10 Prolene that I put through the needle. This is a 1-inch 27-gauge needle. There's that scratch. Only need a scratch. That's all you need. You go through the either a main incision or something like that. Engage some iris, push through the sclera, and the first thought I had watching the video was, you're going to cut the suture with the sharp edge of the bevel, but amazingly it doesn't. It just doesn't. I don't know. Maybe not enough force, or not. It's not sharp enough. So you just do the thing over and over again, push through. Now you got a loop. So basically, there you pull the loop out, give yourself plenty of room. Then you retract the needle again, and you just do it again and again. So for the sake of time, I'll fast forward this. And yep, same thing, third loop. Then I'm threading that tail through every loop. See, I got it through all the loops there. Then I find that last suture, which is still attached, and I just cut it short, tie the knot, and then we're good. It's a little bit peaked there. I stretch it a little. I think it'll be okay. So here's the post-op picture about a month out. She's 20/20 still. She's happy. That was a lot of glare that we eliminated. This is where that cut was. Questions on that? Yeah, go ahead.
Are you, when you throw it through the last loop,
Yeah.
are you tying it to the last loop, or what are you tying it to make the knot? Or are you just kind of like...
Well, the last loop will come out. You just cut the loop off and then tie it, and then you pull the rest through the out of the eye.
Okay.
So you cut the last loop and it's cut. Good. I think we're pretty much done. This is a really cool thing that'll take about 2 minutes. This is fine-tuning pupil centration if you're really picky. And this is called iris diathermy shaping. How many people have heard of iris diathermy shaping? Just a few. This is pretty cool. So you take, these are retina cauteries, about bipolar pencils, and the ones I get are from Curran. I've tried 23 gauge, 25 gauge, 27 gauge, and I found that 23 gauge is just a sweet spot. You plug it in, whatever phaco machine you have, just dial the power down to the minimum. And I'll just fast forward this. So I'm done with the, this patient had a scarring of his iris. So I'm done with my seeps, I put the lens in, but it's kind of teardropped and oval. There's more iris on this side than this side. And again, this is very subtle. So here I am with my diathermy probe. The further back you touch the iris, the more broad effect you have. The closer you to the pupillary border, the more focal you have. So now I'm just touching. It doesn't look like it's doing anything, but when you script through the video, you'll actually see the pupil getting rounder and rounder, and it's actually like magic. So I tell the staff this is like the magic wand. It just makes it like, it's just such a good feeling when you're done with the case, and then you just make it just that much more round. So here you are comparing like an ovalish pupil to a rounder pupil. And here's another representation. Here's a crazy traumatic case or something. In this case, the pupil was not totally centered. You can look for the Purkinje reflection on the cornea that it's, well, now the eye is about right there. So then you can actually use it. Here's a diathermy pulling the pupil. Now it's perfectly centered. Isn't that cool? Okay, so on that note, we'll end for the sake of times.
Thank you, Jason. Let's give Jason a round of applause. I will make mention that online, this whole talk is there, and you'll actually be able to see the videos even better. They're clearer as we were watching them on the show there, so you can see them very well, just like on your computer. I had two questions, Jason. One is there what code, I mean, does you get a good code for a more round pupil?
No.
Is there, I mean, there's one code for this, is that correct?
Yeah, the code I use is 66682, which is, I think its description is like suturing iris with mechanical suture, I think, something like that. That's, even though you spend a lot of time or not so much time, it's the same code, unfortunately, but
That's what I figured.
I like to make it.
Now, the
look
last
nice.
question was, does MST also sell the amount of patients that an inpatient cataract surgeon needs for this technique?
No. But
No, oh, okay.
Oh,
So it's not
yeah.
for everyone, not for the lighthearted, not for the impatient?
No, it's not, but it does make a difference in those particular patients. Even in the mission field, I've had patients with no pupil because they had some M6 botched surgery and their pupil is dragged all the way to the incision. I don't know if you've seen that before. And to be able to release all the scar tissue, reconstruct the pupil so it's in the middle and they can see, it's a big difference. Yeah, it takes time. And if you're having a high volume and you don't have time, then you probably leave that for last. But if you do have time, it can make a difference.
Absolutely.